So Shane did a beautiful job of going through about a third of what I'm going to tell you as well. But that's the good point of this, which is, we're going to hammer home some concepts and look at it from a little bit of a different perspective. So you just heard about how when you have a small left side of the heart, how do you determine whether it is too small or small, but we can do something else to it to rehabilitate it. I'm going to take the other tact and talk to you about the conditions where we know things are too small, but also talk a little bit about that differential, but from the other extreme. So I think you'll find this helpful. Hypoplastic left heart syndrome is not a single condition. It's not a one diagnosis. It is a grab bag categorical term for a variety of different conditions in which the common theme is inadequacy of the left side of the heart. So for whatever reason, the left ventricle, which is supposed to be the ventricle that pumps the blood to the body, can't do what it's supposed to do, isn't of the proper makeup to do what it's supposed to do. And the term hypoplastic left heart syndrome was first described in the late 1950s by Alex Natus and Jackie Noonan. Jackie Noonan was actually, of the Noonan syndrome that you may know of, was actually a cardiology fellow at the time at Boston Children's. And the two of them coined this particular term. We now use it to include, again, a grab bag of a variety of different conditions. The classic form is where there are normally related great vessels. The left ventricle is small, either with mitral stenosis or mitral atresia, and aortic stenosis or aortic atresia, and inadequacy of the left side to do what it's supposed to do. But as you see here, there are a variety of different anatomical variations that also can be considered HLHS. As somebody who cares for kids with HLHS, parents, when I'm counting them, often will ask me, well, what's the oldest patient you know of with HLHS? And so I show this to you in somewhat of a humorous way, but it turns out that there was a report in The Lancet in 2015 of a mummy, a 6,500-year-old mummy that was found in the Andes and sits in the museum in Detmold, Germany. It's otherwise known as the Detmold mummy. And it's a mummy of a child in a sitting position, a few months of age. And then, of course, as it goes with mummies, somebody decided finally to take a CT or an MRI, and this is actually a CT, and take a look at the inside. And it turned out this was actually a child that had died of hypoplastic left heart syndrome back 6,500 years ago with aortic atresia, a very tiny aorta. So this condition has plagued human development for quite a long time. It's not something that was just discovered in the 1950s by Natus and Noonan, but it's been around, part of the variety of birth defects that exists. Fast forward to where we are today, this is how we identify HLHS most commonly, and it's by referral for a mom at 13 weeks with a cystic hygroma in the fetus, and not sure exactly what's causing it. We take a closer look at the heart. This is, again, an old echo, but you can see here that there looks like there's only one AV valve and one ventricle, and maybe a little bit of an effusion, pericardial effusion as well. And we put some color on, and again, it just looks like there's a single valve. Can't really fully delineate, perhaps in this case, exactly what's going on, so we had the mom come back at 18 weeks. And here you can now see that this is a single right ventricle. There is a single AV valve. There's a small left atrium. This is hypoplastic left heart syndrome. We can take a look at the aortic arch. I've labeled the position of the fetus. You see the back, posterior, anterior, caudad, and cephalad. And that's a picture of the aortic arch. The striking thing here is that there is red flow in the aorta, which means that there's retrograde flow. You should never see retrograde flow in the aortic arch unless there's some abnormality. It turns out this is a case of aortic atresia. This blue jet here that you're seeing is ductal flow. And get a look at the size of this aorta here. We have some of the markers here. So this is a 1 centimeter marker. And that's about 1/10 of the size of this distance here. And take a look at what this aorta looked like in the operating room. It's this tiny structure right here. This is a typical appearance of aortic atresia in HLHS, where you have a very, very small aorta, which essentially functions as your common coronary artery. So this aorta is about the same size as it was at the 18-week assessment. So this is a case of aortic atresia, mitral atresia. Often, I'll bet that this is a common way that sonographers identify HLHS, and it's by the presence of a left ventricle, but one that is very abnormal in its makeup and morphology. Here you see to use Shane's term, again, a short and fat left ventricle, but also with a valve, a mitral valve, that really is not opening too much, but the fact that there is a cavity at all probably suggests that there is some degree of flow into this left ventricle. It is very muscle-bound, poorly contractile, and the cavity itself in comparison to the right ventricle is quite small. Put some color flow on, and the scale is relatively low at this point, but we still don't see too much inflow into this left ventricle. Here's the right ventricle, but what you do see are these little jets of flow surrounding the left ventricle, and these are coronary cameral or coronary to LV cavity fistulous connections. We have a very hypertensive, hypoplastic left ventricle under high pressure, and so it's developed in a way such that there are connections between the coronary arteries and the cavity of this ventricle itself, and blood will make its way in and out of the cavity through these coronary fistulous connections. Again, something you see in mitral stenosis or mitral hypoplasia, HLHS, not in the mitral atresia, HLHS patients. And then moving along the spectrum here of left ventricles, and again, we just heard a very nice description of this phenomenon. There are some fetuses who have aortic stenosis that evolve into HLHS. I will say that of the spectrum of all HLHS that I see, and I think this is the case, worldwide, the AS, the aortic stenosis evolving to HLHS subtype, is a very, very small fraction. And in our series we've recently looked at, it's about 3% of fetuses. So I say this because it's important when a diagnosis of HLHS is made, because of the drama and the advances and the excitement about fetal intervention. Often a family will say, well, am I a candidate for a fetal intervention? When the fact of the matter is that 97% of fetuses that have HLHS are not candidates for a fetal intervention because they don't have this aortic stenosis evolving to an LV. It's a very small fraction of overall patients with HLHS. But nevertheless, this phenomenon, interestingly and curiously, does occur, and it's attracted our attention. And so here's a dilated left ventricle with aortic stenosis. There is left to right shunting at the atrial level, and you see the LV itself is dilated. Nobody would say that this is hypoplastic. At this point in time, we look at the aortic arch, and there is retrograde flow in the aortic arch, as you see here. That study was done at 19 weeks. Take a look at this patient at 33 weeks now. The left ventricle is the same size it was at 19 weeks, but is now shrunk relative to the right ventricle. We have clear-cut HLHS. So the objective here is to see if perhaps we can interrupt this process by dilating the aortic valve and preserving the LV function, as we just saw a few minutes ago. In general, here are the things you should be looking for in all normal fetuses. You should see right to left flow at the atrial level. Again, we're going to hammer away at this because these are important points. And anterograde flow in the aortic arch. When you see an abnormality of the left ventricle and there is left to right shunting at the atrial level and reversal of flow in the aortic arch, that's a sign that that left ventricle is at high pressure and inadequate to do what it's supposed to be doing. And that's one that we can predict with some degree of reliability is going to evolve into total inadequacy and HLHS. And to reiterate this other point about the long and skinny, again, each of us, I think, as fetal cardiologists, have a story like this. This is a patient that came to us from another center at 37 weeks with counseling on HLHS. This left ventricle is so tiny, it's small, it's not going to be able to do what it needs to do. You need to go to a surgical center. Came to us, we looked at this, and we said, yeah, that left ventricle was pretty small, but it is long and skinny, and the arch looks very abnormal. There's a retrograde flow in the arch. But most importantly, despite the inadequacy of the size of the left ventricle, again, this is your take-home message from these two lectures, look at the atrial septum. It is bowing all right to left. That you cannot have an inadequate left ventricle and have the atrial septum bowing right to left. It would have to be shunting left to right if that left ventricle is inadequate. And lo and behold, we did absolutely nothing for this fetus except allow it to deliver. And this is about day 5 of life. Look at that left ventricle. Totally normal. And compare it to the left ventricle that we saw prenatally here. Now, there was arch narrowing. This this newborn, underwent a coarctation of the aorta repair, but the left ventricle was totally normal. So once you've identified inadequacy of the left ventricle, here are the key elements of what you need to look at. And again, this is in your syllabus. It's characterization of the LV, looking at the mitral valve, aortic valve, the atrial septum that we're going to spend a little bit more time looking at here in a moment, and pulmonary venous Doppler that goes along with what the nature of the atrial septum is. Right ventricular function, tricuspid regurgitation, if it's present, because the entire strategy for care here is going to hinge on using the right side of the heart to take over the job of the inadequate left. And so you need to make sure that that right side is functioning properly. Middle cerebral artery and umbilical artery Doppler flow characteristics are often helpful, and then looking at growth parameters in these fetuses. 2 key things to look at that add risk to the entire undertaking are the nature of the tricuspid valve and the atrial septum. So let's spend a few minutes talking about that. About 5 to 7% of fetuses with HLHS will have some degree of significant tricuspid regurgitation. The right ventricles in these patients are typically not normal. So when you have HLHS, it's not as if, only one chamber is affected and the rest of the heart is totally normal. There is a compensatory accommodation that takes place. If the left ventricle is inadequate, all the cardiac chambers are related to each other. They're all connected. It's all one structure. So if one chamber is dysfunctional or inadequate, it's going to influence the other chambers in some way as well. So typically the right ventricle is more dilated in HLHS, and its makeup and morphology can be different as well, and in particular the tricuspid valve can be different. Here you see a particular case of HLHS with a very dysplastic tricuspid valve, and it is leaking fiercely, as you see here. When you see this prenatally, you may have to consider the fact that this may not be a candidate, a good candidate for a surgical reconstruction, and so this becomes a risk factor. Now, mild tricuspid regurgitation, quite common, and in fact, there are many patients who continue to have persistent mild tricuspid regurgitation throughout their reconstruction and into their adult years, and that remains stable. Different than the severe tricuspid regurgitation that you see prenatally here. The atrial septum and flow across the atrial septum. Again, we're going to hammer away at this. It's important, I think, that you take this take-home message about direction of flow of the atrial septum and begin to become comfortable with looking at the atrial septum. This is a box diagram of normal fetal flow, right to left. The left ventricle fills with pulmonary venous return and with what's coming across the atrial septum. Nature has beautifully designed the flow from the umbilical vein to make its way to the ductus venosus, and the ductus venosus has this narrowing and crimp in it to naturally accelerate flow and angle it right at the foramen ovale so that that highly oxygenated blood makes its way to the left side of the heart, preferentially. Why? Because the left ventricle is going to deliver blood to the coronary arteries and to the cerebral circulation, 2 organs, heart and brain, that require a bit more oxygenation during the development. And nature has beautifully done that. However, when you have HLHS, that scenario is disturbed. And so you have an inadequate left ventricle, your left atrial pressure increases, and although your ductus venosus is still going to stream into the right atrium, it's going to compete with a force coming at you left to right at the atrial level. And this is what we see in about 95% of HLHS patients, that there is some degree of decompression of the left atrium. However, in about 5%, something else can occur. You can have inadequate left-sided structures, but also some degree of restriction at the atrial septum that then raises that pressure on the left atrium even further and can obstruct the pulmonary veins. When the pulmonary veins are at high pressure throughout development, that can lead to histological changes, histopathological changes in the lung that we and many others have described. We first described this back in 1999. I think I was in 2nd grade at the time when I did this paper, or something along those lines. But it was quite a while ago where, unfortunately, we had a lot of pathology of newborns with HLHS and an intact or highly restrictive atrial septum. And we looked at the pulmonary vein histopathology. What you see here is what the pulmonary veins look like in an HLHS with an open atrial septum, normal structure. And this is what it looks like when you have an intact atrial septum. Again, these are pulmonary veins with the phenomenon of arterialization and an increased elastic laminae, sort of the wall of the vessel changing in relation to the high pressure and the obstruction. And therefore, fetuses that are born with this condition not only have HLHS and may have trouble in blood getting out of the left atrium and be quite blue, but even if you can open that atrial septum, their lungs are damaged. Their lungs are different in some way. And so sampling the Doppler, sampling of the pulmonary veins is critically important in HLHS. By dropping your color scale, you can sample the pulmonary veins, and typically this is what the pulse wave Doppler will look like. It's a triphasic pattern of where you have a little bit of reversal with atrial contraction, mostly anterograde flow and systole, and some more anterograde flow and diastole, but the predominance of flow is forward, as you see here, with a little bit of retrograde flow. Compare that to a fetus with an intact atrial septum and HLHS. Where's that blood from the lung going to go? It doesn't. It connects to a tense left atrium here. The pulmonary veins are dilated. And when we sample in the pulmonary veins, we get a very characteristic pattern. This being what is normally seen, again, a little bit of retrograde flow with atrial contraction, but mostly dominant forward flow, versus a fetus with an intact atrial septum, where essentially when you Doppler the pulmonary vein, the blood is sloshing back and forth between the pulmonary vein and the LA. It's not progressing forward. You see an equal amount of forward and retrograde flow. Now, this is not an all or none phenomenon. It occurs in a graded manner depending upon the degree of restriction at the atrial septum. In panel A, you see a normal flow. Panel C is what you see when you have a highly restrictive flow. Panel B is kind of a borderline case. And so a variety of groups have now started to look at this. And for quite a while now, we've had various criteria that help us look at the ratio of retrograde flow and anterograde flow and determine to what degree there is restriction at the atrial septum, and then use that information to help guide what we may want to do postnatally and to counsel families as well as to whether or not we may or may not have a high-risk candidate for surgical intervention. When you have restriction at the atrial septum and impediment to egress of blood flow from the left atrium, you get this backup pressure into the lungs. It can damage the lung. Another way for us to characterize the lung in the current era is by using fetal MRI techniques. And a variety of centers have now started to do this routinely. What you see here is what the lung looks like when you have an open atrial septum, normal lung parenchyma pattern, versus when you have an intact atrial septum. You get these stria within the lung itself, and what's referred to as a nutmeg lung appearance, indicating the presence of lymphangiectasia. This is a risk factor. I think important for this audience to know also what it is that we do with this condition and where we are currently with our management of HLHS in the year 2022. There is a three-staged approach to reconstruction. It starts first with the notion of switching the task of delivery of blood flow to the body and to the lungs to the single right ventricle that's there. This initial operation is referred to as a Norwood operation or a stage 1 operation. The aorta is rebuilt, the intraatrial septum is resected, and a source of blood flow is created. Then at about 4 to 6 months of age, a second stage is undertaken where the superior vena cava is directly connected to the lungs. The idea here is, if nature's only given you one functioning pumping chamber, your right ventricle, and your left ventricle is gone, you need that ventricle to deliver blood to the body. The body demands pulsatile flow, but the lungs don't. And this is an amazing thing. Every time I describe this to families, it's sort of mind-boggling. But you can connect the veins that drain the blue blood directly to the lungs without the benefit of a pump, and that works. Not perfectly well, but quite well, interestingly. And we can't do it all at once in the newborn period because the lungs are not fully developed yet. The pressure in the lungs is too high. So at about 4 to 6 months of age, we can take a child and connect the superior vena cava to the lungs. That allows for adequate blood flow to passively flow into the lung without the benefit of a pump. And then at about somewhere between 2 years and 4 years of age, a fairly wide window, we do something called the Fontan operation, which is the third stage where we take the inferior vena cava flow and we direct it into the lung. And when one is done, superior and inferior vena cava flow make their way passively without the benefit of a pump into the lungs, makes its way back through the left atrium, skirts the left ventricle, that's non-functional, and then enters into the right ventricle and gets pumped to the body. So a little bit of a cartoon diagram here of what this looks like here for the initial stage operation. This is something we show to our families to help explain some of this. Here's your small aorta. We're going to zoom in on the aorta and the pulmonary artery. In this case of HLHS, the aorta is highlighted there in the color red, and it is amalgamated, connected to the pulmonary artery, and additional material added, so we rebuild the aorta. But that aorta, that newly constructed neo-aorta, is now coming off of the right ventricle. We need to open the atrial septum. Pulmonary veins come into the left atrium, so we cut out the atrial septum and allow for blood to readily make its way from the left atrium to the right atrium. And now we need a source of blood flow to the lung. This can be done in a number of different ways in the current era, but what we're going to show you here is the more classic Blalock-Taussig shunt, which is a tube of Gore-Tex that's interconnected between the innominate artery and the right pulmonary artery. So this is our stage 1 Norwood operation. One of the most complex things that we do in congenital heart surgery, but it is something that's readily done now at major centers around the world. Here's a paper that we did quite a while back, but much of the data here still holds true, and it was a review of a series of fetuses that came to us with the diagnosis of HLHS over a 5-year period of time, and we stratified patients based on particular risk factors. So if there was prenatal tricuspid regurgitation or intact atrial septum or extracardiac anomalies, a genetic or chromosomal anomaly, or any prematurity less than 34 weeks, that was a risk factor. And if you didn't have any of these, you were standard risk. I'm not going to say low risk, but standard risk. And what you see here is the outcomes for these particular patients. 240 consecutive fetuses with HLHS. 162 were standard risk. 78 were high risk, so about a third had some risk factor. 28 of these terminated. It's a relatively low rate of termination, I have to say, because this is a selected group. Families that come to Children's Hospital Philadelphia and other major centers have already decided that they want to undertake this care. But nevertheless, it was a little bit over a 10% termination rate. Intrauterine fetal demise for HLHS is extremely low, occurred in only 3 out of our 240 patients, and all 3 of these patients had Turner syndrome, interestingly. Turner's is associated with left-sided heart disease. 21 patients chose non-intervention, in other words, palliative care at birth. 3 underwent a heart transplant at birth, primarily because of severity of tricuspid regurgitation. That leaves us with 139 that were standard risk, 46 that were high risk. Again, high risk factors, significant tricuspid regurgitation, intact atrial septum, extracardiac anomalies, genetic chromosomal anomalies, or prematurity less than 34 weeks. And so what were the outcomes for their stage 1 Norwood? About half survived in the high-risk group, and in the standard risk group, it's over 90% survival. And again, this data is about 10 years old. The results have only continued to improve. Now, why am I going through this exercise here? Because I want to emphasize the value and importance of prenatal characterization. Once you make the diagnosis of HLHS, what risk factors exist? Getting an amniocentesis, getting the best sense of the genetic and chromosomal makeup of these fetuses is important for counseling. And of course, doing everything that we can to obviate prematurity and such. If that's the case, I can counsel a family and say there's a 9 out of 10 chance. Look them in the eye and say there's a 9 out of 10 chance you're going to take your baby home after a stage 1 Norwood. Whereas if you have any of these other risk factors, it depends on what those risk factors are, your survival outcome could be as low as 50% or even less if you have, for example, an intact atrial septum. So that's important, I think, from a counseling perspective. What happens next is, real quickly, just a cartoon to show you how we proceed forward. After the stage 1 Norwood, at about 4 to 6 months of age, the Glenn operation is undertaken, where the superior vena cava is connected end to side to the right pulmonary artery. And then at 2 to 4 years of age, children come back and have their Fontan operation, where the inferior vena cava is disconnected from the right atrium. A couple of different ways to do this. What you'll see here is something called the extracardiac conduit type Fontan, where a tube graft is connected to the inferior vena cava and then carried along the side of the right atrium with a connection to the superior vena cava pulmonary artery. The greatest mortality for this really exists at the initial operation. The Glenn and Fontan operations have over 95% survival outcomes once you make it to those points. A lot of focus in our field on this particular condition, a lot of energy, both intellectual as well as resources that are provided for the maintenance of these particular patients. And so some of the things that we're learning now, I think that connects the dots between what we see prenatally and postnatally. So I showed you at the beginning of my talk here as to how we initially make these diagnoses with the cystic hygroma or such. Nuchal translucency, still commonly utilized today. Here's a fetus at 12 weeks with an increased NT of 0.37, assuming basically 0.3, 3.5 millimeters is going to be your upper limit of normal. Now let's fast forward that to what we're now doing in many of our survivors of HLHS, and that's utilizing MRI techniques to look at lymphatic characterization. And so there is a connection between the lymphatic abnormality that we see at 12 weeks, the lymphatic derangement of an increased nuchal translucency, and some of the lymphatic abnormalities that we're seeing later on in life in the survivors of stage reconstruction. Now, I'm just sort of waiting for the study to be done and would love to be able to coordinate this in some ways to follow these patients longitudinally to see whether NT does in fact potentially predict whether we're going to have some of the lymphatic difficulties we see in some of our patients with single ventricle. We're getting to that point, I think, because these sort of developments occurred in different eras, but we're getting to that point shortly. What can we say today about the single ventricle journey? I was asked this study was prompted by a question I was asked by a family, which was, okay, as we sit here today in counseling of 20 weeks, what's the likelihood that my child, my fetus, is going to be alive and well at 5 years of age? And, many of us kind of sit with our papers and we start to do the math and we do the statistics and such. And I said, that's not the right way to do this. You can't start multiplying statistics here. Let's answer the question of just doing a single longitudinal assessment of fetuses and looking at how many of our patients are 5 years of age. And some of the larger centers can do that. And so had this discussion with Michael Liu, who was a fellow at the time at CHOP, and he said, okay, we'll take this on. And so we looked at 500 consecutive patients with single ventricle that we knew came through the fetal heart program at CHOP and had made their way, or would have been expected to have made their way through the Fontan operation. So of these 502, 348 survived to live birth with intention to treat. And of these 348, 234 survived 6 months after their Fontan operation. So the answer to the question is, what's the likelihood if you have a fetal diagnosis of single ventricle in the current era of making your way through the Fontan? Is 2/3. 2/3, all comers. Now, again, there are different types of single ventricle. There are different risk factors that we just talked about. But the immediate answer is, I think, an amazing one, which is in the current era today, we have a pathway of survival for patients with this otherwise lethal condition. And that, I think, is one of the greatest, I think, advances in our field when it comes to birth defects. Now, the next challenge, of course, which is a subject matter for another conference, not a field conference, is what do we need to do to take these fetuses and these children and create a normal quality and duration of life for them. We now know, with about 25, 30-year experience in following patients, that there is a decrement in their survival. About 80, 85% of patients will survive the Fontan operation out to 25 years, but very few of them will be free of most morbidities. And there are a variety of morbidities that are associated with this abnormal circulation. So I just described to you the sort of the miraculous thing that you don't need 2 pumps to live, but you do need 2 pumps to live a normal life. And so there are consequences in relation to the Fontan operation itself. So HLHS is a complex form of heart disease. What I wanted to do is give you a real snapshot of the spectrum of what we see for these patients and how they exist. Many other factors besides the heart influence outcome. I think important for you to be armed with this basic information because, again, you folks are the front line for making these diagnoses. Thanks.